Hello and welcome everyone. This is Amy Adams with the California Healthcare Foundation. Thanks for joining today to talk about provider directories. Hope everyone had a good holiday weekend. Especially impressive that you are turning out for this webinar after that 3-day event. So today, Jonah Froelich and Keith Nevitt, both from MNAT, will be sharing findings from research they recently completed examining 4 states that have mounted integrated provider directories. Just to flag for folks, an issue brief with more detail is forthcoming. Next slide. After I give a little background, Jonah and Keith will present, and then there will be time for questions and discussion after the presentation. A few housekeeping notes, just so folks know, attendees are in listen-only mode. Just so everyone knows, this session will be recorded. So make a note of that to yourself. And then slides in the recording will be posted on the CHDF website. That'll probably happen within the next week. When we get to the question and answer section, to ask a question, any logistical questions, if you don't mind, you could use the chat function, send to the host, and we'll try to respond. And if you have substantive questions for the speakers, you can use the chat function to the host and the panelist. And at the end, this is Amy again, I'll be moderating the questions. And we've left significant time for questions and discussion. So just to remind everyone what we're talking about here, a little definition of the integrated provider directory. I think a lot of the research, however, is actually applicable to even provider directories at the individual plan product level. And just to provide a little bit of context and background, as California has struggled with how to provide consumers with accurate and useful information about health plan provider networks, the Foundation commissioned this research to see what we might learn from other states that had grappled with these challenges. So initial research led Jonah and his team to identify Colorado, Maryland, New York, and Washington as states where state-based marketplaces had mounted integrated provider directories. The team then interviewed a wide range of stakeholders, consumer advocates, purchasers, including state-based marketplaces, state Medicaid agencies, regulators, carriers, and providers to get insights into the different challenges and potential solutions. The team also talked with many stakeholders in California to understand how what they were learning might apply here in our state. And related to that, I wanted to especially acknowledge that we're very grateful to the advisory group consisting of California experts and stakeholders that have provided feedback along the way during this process. So now I'm going to turn it over to Jonah, who will dig in deeper. Jonah, you want to take it away?
Great. Thank you, everybody. And thanks for joining our webinar today. So I wanted to make sure that it was clear the perspective by which we were conducting our research, and the issue brief that will be forthcoming will use the lens of the consumer perspective to describe and discuss the issues around provider directories. And one way we've sort of looked at this is to sort of try to articulate how consumers are using other products like Amazon.com or services. And in that way, they have information to understand where services, where products are manufactured, who makes them, and there are certain rating systems that you can access. You can see how others who purchase that service or that product have used them. And healthcare.gov and other marketplaces have that kind of promise as well, that you can go online, you can actually look and see different insurance products, you can browse, and you can select based on a number of traits. And that's ultimately what individuals who are both shopping for insurance products and are using those insurance products are coming to expect and want from the experience of actually acquiring healthcare insurance or coverage. And so that's really the lens that we took. So we know that this is a journey, that we're making our way towards this. And this is how we began our investigation. So really looking from the consumer perspective, what are they looking for? What kind of information are they seeking? And specifically around the use of provider directories, how would they be using those directories to both purchase insurance and to use insurance once they have them, once they have it. So we took a look at the federal landscape to set the context here. And there are a few areas that we looked at in particular. One is around qualified health plans. Now, there have been rulemakings that have taken place in the last few years, and they've resulted in a number of regulations, both in QHPs and in other areas, both Medicaid and Medicare. On the qualified health plan side, state and federal marketplaces must include information like provider licensure, specialty contact information, and institutional affiliation and panel status when posting their directories and updating them. In the federal marketplace, those data must be submitted at least monthly, and they need to include whether providers are accepting new patients. And then Health and Human Services, which oversees ultimately QHPs, may impose civil monetary penalties should a qualified health plan on the federal exchange provide incorrect information. That hasn't happened yet, but that is in regulation stipulated. For Medicare Advantage organizations, MAOs, MAOs must contact providers at least quarterly to confirm that the information is correct and are required to make real-time updates. And inaccurate or incomplete directories, like in the QHP regulations, may result in monetary penalties as well, and other things like enrollment actions, which could include things like suspension of enrollment activities in the Medicare Advantage plan. Similarly, there are federal requirements around Medicaid and CHIP managed care carriers, and in this case, directories are supposed to be maintained with information on physicians, hospitals, pharmacies, other types of providers, including behavioral health and long-term services and supports providers. And then finally, NAIC, the National Association of Research Commissioners, proposed some draft model legislation. And that included, there was directed towards provider directories. And back in November 2014, it really was a draft model legislation on health plan network access and adequacy, and we really focused on the issues around the directory that were included in that model legislation. So those were included as part of our national landscape too. Now, in California, there have been a number of recent developments with respect to provider directories, and we wanted to highlight a couple of areas that have really sort of risen to the forefront. One is that, as many of you know, the Department of Managed Healthcare, DMHC, under Chapter 2 of the California Health and Safety Code, requires that carriers update directories quarterly, and that they include certain elements. And in recent audits, they've identified some inaccuracies in at least 2 large carrier directories. That was reported towards the end of last year. And then earlier this year, the California Department of Insurance issued emergency regulations to strengthen network adequacy. As part of that, and again, the focus is on directories in our work, not on network adequacy per se, but as part of that, directories of CDI-regulated plans, and as many of you know, CDI regulates a lot of the PPO plans and some others. They must include demographic information, status of practice, and other elements. And then recently, Senator Hernandez introduced SB 137 that's been moving its way along in the state, and it is intended to improve provider directories and specifically to require weekly updates, and it directs the state to develop standard provider directory templates, the standard mechanism for which these, a template for how those information are displayed or data submitted. And then even more recently in June, the California State Audit Report examined the Department of Healthcare Services oversight of Medi-Cal managed care plans, and what it found is that 3 carriers had some significant inaccuracies in their directories, and that the department had a provider directory review tool and process was not sufficient. So those have all been brewing really in the last 6 months or so in California, and similar types of issues have been occurring in other states as well. This is an increasing area of interest. Now, we wanted to make sure that it was clear as we were developing this paper, and for those who are on the phone, what goes into and how are directories typically built and maintained. And so there's a life cycle to a directory. And the way that we've described it here is as an ecosystem. So when the genesis of a directory would start with a health plan, a carrier that would develop a product with a set of benefits. It specifies the regions in which it will be offered and the networks of the providers that will support that product. So it develops this network and it enters into contracts, or it amends contracts with terms and policies with the whole host of providers, whether they're pharmacies, et cetera, physician groups, hospitals that will be part of this network. Now, those contracts may require certain data to be provided. And when we did our interviews, we found the fact that every health plan we talked to had some contractual requirement for providers to submit data to support and maintain and manage and update their directories. And they varied in terms of what they required. But they require things like for hospitals and other institutions, name, locations of services, and licensing. And that for physicians and IPAs, they'd have name, national provider identifier number, specialties, locations, the name of the medical group, languages spoken, open or closed panel, whether or not they're accepting new patients, and contact information. So those were the general data elements that we found when we spoke to plans that they'd have in these contracts. Now, there's this linkage between these data elements and the health plan and the credentialing process. So in some cases, the health plan credentials the providers in California. In many cases, in a delegated model, an IPA would actually do credentialing. And in the credentialing process, IPAs or plans would inquire and note whether and how the providers are licensed. So they go to the licensing boards. They look for verification of things like education, license, especially areas of standing, and other items. Now, all of these elements ultimately get incorporated into a new directory that is relevant to the health plan that was being developed. So it has a directory, and this health plan has a directory, a set of benefits, and the health plan will develop other products with a similar set of benefits and directories that it manages and maintains. Now, those products ultimately are sold by plans, by brokers, et cetera, to individuals and employers and marketplaces. So they will go directly to an employer, or in the case of in California, Cover California, they go direct to Cover California as a qualified health plan, meet other functions and requirements, and be listed there. And ultimately, in the case of Cover California or other plans, you would roll these up and have something that we would call an integrated provider directory that would list all of the plans, all the products, and all the directories. And those were the 4 states that we looked at that they had that functionality, those rolled up services and directory. And ultimately, this was used for many purposes, but in our context, the consumer used this to directly access information, to help make a selection of the plan and the product they wanted, and ultimately as well to help identify the providers that they may want or need to use in the event of medical need. So that's really the purpose of these directories in this context, which is to inform consumers about the products they want to purchase and the providers in the network that they can access. And then in the bottom corner here, we have health insurance regulators who oversee, direct, and guide and regulate how these directories should be maintained. So they issue guidance and regulations about those issues. So essentially, this whole ecosystem really suggests that there are many, many actors that are involved in this, all the way from the state, which has both a role as a contractor, whether you're the Department of Healthcare Services and you are contracting with managed care plans, or you're a marketplace and you're covered California and you similarly contract with carriers, there are a host of contracting, this chain of contracts from the state and marketplace employers all the way to carriers, groups, IPAs, hospitals, and other institutions. And in some of those contracts, there will be provisions about directories and the kinds of data that need to be included in and submitted to support those directories. And then there's this data flow aspect, this cascade of information that flows from individual physicians or hospitals, pharmacies, and in the case of a delegated model, it'll go from individual physicians to IPAs and then up to carriers that would help to populate those directories. So there's this cascade of contracts with some of which have certain provisions, some of which include potential implications if those provisions are not followed, and then this chain of data that flows all the way up from the individual physician, in some cases up to the marketplace and the state. And so there are opportunities all along the way for the chain of data to break in some cases. And in contracting, there may be places where you don't have provisions that require data to be submitted. So there are opportunities almost everywhere for breaks along this cascade. So that really sort of sets up the context. What I'd like to do is turn this over to Keith and to have him walk through some of our key findings in the 6 domains that are listed here on slide 12. Keith, go ahead, please.
Great, thank you, Jonah. So as Jonah said, I'll walk through at a very high level due to our time constraints here, some of the key findings that we took away and were able to synthesize from, again, over 30-plus interviews and really a deep dive into this. So to jump right in, the first main area we really found was around shared accountability, and really the takeaway we had here was that the lack of enforcement of regulatory and contractual requirements really does create an environment that doesn't foster shared accountability. So as Jonah just mentioned and walked us through that cascade of actors, each actor along that way has their own unique processes, systems, and requirements. So even though the system is interdependent and each actor is heavily reliant on the other for data or for contracts and expects everybody to hold up their end of the bargain, there really is no one coherent system that shares accountability across all the actors. All of the contracts that we found between carriers, marketplaces, state Medicaid agencies, basically anybody who has a contract does include provisions around requiring accurate and timely data submissions, and also the contracts do specifically outline penalties or remediation measures for failure to do so, and some of those penalties could include things like de-delegation of groups and suspension of assignment of new beneficiaries, or even the issuance of a corrective action plan. But even though those things exist in contracts, we found only one carrier that actually reported enforcing penalties on providers, and we found that although these do exist in contractual language, marketplaces and state Medicaid agencies did not report enforcing penalties really on carriers at all. And then another wrinkle that's added in is that especially marketplaces, as they are attempting to aggregate and report all of this data, are really reluctant to alter the data that's being provided by the health plans, by the carriers, due to data ownership and liability concerns. And there really was a pervasive attitude or belief that that the idea in the industry is really that the plans and the carriers are the ones that sort of own the data, and there's a real hesitation to edit or alter that data even when an error is identified. So all that being said is there's really, because there's little real enforcement of penalties, that translates directly to mean there's really no incentive to invest the time or money in the processes needed to create accurate directories. Our second area was around policy and regulations. We found that aggressive regulatory actions in New York State are actually creating incentives for industry stakeholders to monitor and update provider directories, and much more so than in other states. So we began by finding that actually the New York State Attorney General has taken actions over the past 5 years against more than a dozen carriers and reached settlements over the past 5 years in 2010 and 2012, again, to require, quote, ensuring the accuracy of provider directories, implementing new business practices for updating online provider directories in a timely manner, and actually forcing these plans to pay restitution to consumers who paid more than they should have because they saw providers erroneously listed as in-network in a directory. So again, this is really the only evidence we found of direct state action against inaccuracies in a provider directory. And one carrier we spoke with actually, as a result of these actions, completely revamped its entire auditing and updating process for its provider directory. And when it initially did so, the first pass at cleaning and auditing the data found that over a quarter of its provider records were inaccurate or duplicative. And to this day, it finds about 10 to 12% of its provider records on an annual basis need to be cleaned out of the system. So just to give a sense of the volume and the volume of inaccuracies found in the provider directory. And like I said, in states where policies have not been coupled with aggressive regulatory action, carriers really aren't as motivated to improve their directories or processes. There's really no penalties coming down from the state, and in turn, no penalties coming down from the carriers. And we found that there's a number of reasons this is so, but one of the main drivers here is that starting with the state, there really is a hesitation that if you penalize plans too heavily, the plans may choose just to leave the market entirely, and that could leave the market really at a big loss, especially in areas where there aren't many plans participating. And in the same way, carriers are really hesitant to take any action against providers because of the fear that providers will simply leave the network and go somewhere else, and plans may be on the hook for inadequate network size and things such as that. So again, the whole sort of cascade of contracting works the same way in the cascade of sort of this fear of penalization. So moving along, I'm just going to walk quickly through one carrier's processes that we found was the only example of a carrier willing or that even mentioned the ability to penalize providers. And so they start sort of with two different groups of providers, the delegated and large provider groups and then all other groups. And data is submitted to the carrier. Verification of that data is handled either in-house or by a third-party vendor. That carrier uses the data to create their own provider directories, which would typically be hosted directly on the carrier's website. The carrier then submits that data via standardized template that all carriers in New York State must submit through a standardized system that we'll get into in a little bit more detail in just a minute, directly to the Department of Health in New York, and then the Department of Health is able to use that data to create both the New York State of Health marketplace, that's their exchange marketplace, the provider directory for that, as well as the Medicaid provider directory. And then the feedback loop occurs when the state is able to enforce penalties for inaccuracies or require the carrier to submit a corrective action plan if there are deficiencies in provider network or inaccuracies in the directory. And in turn, again, the only time we had heard this mentioned was the carrier may actually enforce penalties on provider groups directly as well. So again, just an example of how this feedback loop may work, and one of the few examples we saw really clearly delineated. Moving along, the lack of both uniform data standards and robust quality assurance processes, quality assurance processes results in really poor data quality and really just not great coordination again. So overall, we found that there are no federally mandated or really industry-wide provider directory standards, and although there is some movement on this now with things like the ONC and the Health Information Technology Committee, there's nothing yet that's definitively come out. We did see that obviously carriers and providers are confronted with a whole slew of different requirements and templates. Many of the systems, as we talked about in that cascade again, are quite homegrown. They've all sort of come out of different ways, and they're all pretty unique. And one strategy that we did see some states were able to use is identifying a submission template and using a template across a number of different agencies or a number of different requirements in order to minimize reporting burdens on carriers. So here in California, DMHC has the timely access reporting template, which allows, plans need to submit annually to confirm the status of their network and enrollment on a county-by-county basis. Covered California was able to partner with DMHC to use that template to collect the information they need for their quarterly network reports. And they also mentioned, Covered California mentioned that they may be able to use the carrier submissions via this template to populate a provider directory in the future. Similarly, in New York, carriers are required to submit quarterly data reports to the Department of Health for all state-sponsored plans, so things like Medicaid and CHIP, as well as the marketplace, and annually for commercial managed care products via one system known as the Provider Network Database System, PNDS. The state provides carriers with nearly 400 pages of data submission guidelines, which really just goes to underscore the complexity of the submission process, as well as the resources the state has devoted to standardizing the process and the resources the carriers need to devote in order to complete this process and submit the necessary information. The New York State Department of Health is able to use this information, as we saw in the previous flow chart, to complete regular network adequacy reviews, as well as create things like the Medicaid provider directory. And the New York State of Health, the state marketplace, is able to use the information to populate its provider directory. So again, one template that's able to be used in a number of different ways. So just a few examples of that. On the data integrity side, although we have marketplaces and state agencies combining data from a lot of disparate from a lot of disparate sources, there's really little done to ensure the accuracy of the data coming in. And so the data coming in is really being reported as is directly out to consumers. And that's where you see on the left a phrase we heard time and time again was garbage in and garbage out. Whatever's coming in is being displayed directly out. Some marketplaces and carriers are able to run provider data against things like licensing databases or sanctioned providers lists to strip out providers that are no longer allowed to practice or things like that. But really no single source of truth exists, and oftentimes these databases or lists may be as inaccurate as the data that's already on hand. Finally, there are some issues along data standards with the way in which facility, ancillary, and leased network data are reported and are able to be displayed. Facility and ancillary data, so for things like labs or clinics, often these things are listed and reported and billed under one parent location, for example. And so in order to list out every clinic location throughout the state or throughout a network proves very difficult and very time-consuming to do, to parse out all the data. Lease networks, which are defined a bit more in the appendix, but basically are networks created by a third party that carriers can actually lease to help increase their network adequacy or increase providers in an area they may not have as big of a stronghold in. These data present even more issues because the carriers may not actually be able to update the leased network data at all, and instead the company that's creating the network that's being leased may have to do it. So it adds yet another layer of complexity into the system. So again, really no uniform standards and very little quality assurance going on. One area we did find some quality assurance going on was in the Washington Healthcare Authority, the state's Medicaid agency. Here we found that each carrier, which would have its own provider directory, is actually required by the state to conduct quarterly reviews of 1/4 of its provider network. So in other words, over the course of the year, it will actually have to contact 100% of its provider network, so actually go out and individually contact each provider listed in its network. And it needs to verify the contact information for that provider and whether or not the provider is seeing new patients. The carrier is then required to submit biannual reports to the state detailing this process and actually submits a list of each of the providers it contacted over that past quarter. And then the healthcare authority, the state Medicaid agency, in conjunction, in parallel, is conducting manual ad hoc reviews of the directory throughout the year and is notifying notifying the carriers of identified issues. So here, one of the few examples we actually saw of some sort of quality assurance going on. For time and resource requirements, we found that organizations, somewhat unsurprisingly, are relying on really time and labor-intensive manual processes to develop and support these provider directories. As you might imagine, resources dedicated to the directories really varied pretty widely. Small plans that are operating in just one state certainly don't have the resources that a large national plan that's operating across many states might have. All the organizations rely on some manual processes to verify and update provider data. Obviously, that incorporates the opportunity for human error into the process. And this may be anything from verifying provider contact information to actually combining different forms and data submissions. Really just varies very widely. We found that this manual process may include lags of up to 2 weeks or more between data submission, review, cleanup, and publishing. So even if accurate data is supplied, it may be up to 2 weeks before that data is able to be taken in, reviewed, cleaned, and then published and faces the consumer. We found that third-party vendors are often involved, adding yet another actor into the system. And although this last point may seem pretty straightforward and obvious, budget and resource constraints really do impact the extent of the quality review that each organization is able to conduct and the functionality of directories. And this is particularly important in the case of Medicaid agencies and marketplaces and other places that may be heavily reliant on state funding in a time where budgets are really constrained, and particularly for the marketplaces as they look to come off federal support funds and become self-sustaining in 2016 and beyond. The idea that they will stand up and maintain provider directories is something that will cost a good deal of both time and money, and is really a decision that each individual marketplace is going to have to face. We found that provider directories really are not adequately or effectively engaging or informing consumers as they enroll in coverage and seek care, which is really, like Jonah mentioned, the lens at which we came through this research. We found that it's important to note that the ACA didn't require that marketplaces stand up these provider directories. So the marketplaces that did try to or have stood up provider directories rather, really did go above and beyond what was asked of them, and have really tried to be the ones out in front of the curve and have somewhat struggled to do so. Navigators and advocates really were and are looking to marketplace directories to be the source of truth and to send consumers there for their questions. But they widely reported that they failed to do so, or they would rather send beneficiaries directly to provider directories hosted on individual carriers' websites due to the widespread inaccuracies they found in the marketplace's directory. So really just a great distrust of what is actually out there. We found that in general, consumers have very little recourse should they sign up for a plan based on inaccuracies in a directory. So they sign up for a plan believing their doctor is in network when in fact they don't, when in fact the provider is not participating in the directory, in the plan that they sign up for, but is listed as such in the directory. We found that one marketplace, specifically Colorado, is willing to create a special enrollment period for consumers who've incorrectly or who have purchased a product with an inaccurate directory. But in general, consumers aren't aware that the directory may be inaccurate, and they're also not usually aware that there is any sort of recourse, or they're completely unaware of even who to report an inaccuracy to, and so the inaccuracies just continue on unreported and unnoticed. And there really is no consensus among stakeholders regarding the necessary data elements needed to create a directory with an adequate level of information. So we really tried to understand what was the sort of the floor for creating a good directory, what information would be needed to do that. And the stakeholders all agreed that there was this balance that needs to be struck between providing consumers with enough information to really make an educated decision and providing too much information that is either confusing for the consumer or is far too much of a burden on the carrier and the providers to keep up with. We did hear a number of elements that were repeated over and over and to be included in a provider directory, and those include things like name, address, phone number, whether or not the provider or clinic is seeing new patients, gender of the provider, languages spoken by both the provider and the office staff, specialties, accessibility for individuals with disabilities, hours of operation, and admitting privileges or affiliations. Other elements that were mentioned here and there included things like proximity to public transportation, email addresses. So again, really sort of a wide range of data that could be included, but no consensus among what needed to be included per se. And finally, there's a real issue around provider contracting. There's confusion that persists with respect to both participation in specific carrier products and requirements and processes available to update provider data by providers themselves. So the main contracting issue that we ran into and we heard over and over again was around all product clauses. These clauses are included in carrier contracts with providers that require that the provider participate in all the carrier's products. And carriers include such clauses to help ease the administrative burden that would be placed both on the plan and their entire network of providers and facilities associated with issuing new contracts and amendments for every new product launch and change. So basically, this allows the carrier to create new plans and new network developments and include whatever configuration of providers they'd like in there. The obvious problem with this, and we saw this happen in many news reports and many anecdotal stories as the exchanges rolled out, is this providers may be unaware that these provisions are in their contracts when they sign on with the carrier, and they may not actually know which products they're participating in. So you may call your doctor to ask if they're participating in the new insurance that you just got through Covered California, and they may not actually be aware of whether or not they are participating in that product. That creates a lot of issues, and actually we found that in at least 6 states, all product clauses have been banned from contracting, but they're still very common here in California and in other places like Texas and New York as well. And so there's a key to this that includes provider education, and that includes both a responsibility on the carrier and the provider as well to ensure accurate and timely data. And to this end, we found that New York State Department of Public Health is partnering with the Department of Financial Services to implement provider education guidelines for 2016, specifically with the goal of reducing provider confusion around marketplace contracts. And with the understanding that carriers and providers share this responsibility for understanding and knowing what products they participate in. As far as updating provider data, we found that carriers offer a number of ways for providers to update information, and this includes everything from phone, fax, and email to actually creating secure web portals where providers can log in and update some of their demographic information. While a lot of these exist and the carriers they all have a no wrong doors sort of policy, some providers reported challenges and delays when updating their information with carriers and cited that even though they've contacted the carrier many times to update that a doctor has left the practice or that they've moved, they really feel that their data isn't being updated in a timely fashion. And again, that lag in when the data comes in to when it's published and is consumer-facing may factor in here as well. So those are sort of at a very high level a number of our findings in how provider directories, some of the issues and challenges facing standing up accurate and timely provider directories. And so with that, I'm going to turn it back over to Jonah to take us through some considerations for California.
Thank you, Keith. So those were the findings from the 4 states that Amy had initially mentioned at the onset of our webinar. In terms of the considerations for California, I want to get to your questions, so I'll go through these relatively quickly. One is around policy and regulatory alignment. What we found in the case of New York is that this consistent guidance and the requirements really did and is helping facilitate the construction of these directories for multiple different markets. So one source of truth or one template, one set of standards is being used to populate, and one tool to populate both Medicaid and their marketplace directories. When you consider California, you've got with the Department of Insurance, with Department of Health Managed Healthcare, the Department of Healthcare Services, and Covered California, and all the plans that support the providing insurance and coverage to those agencies or that are regulated by them. Having some consistency like they do in California would go, like they do in New York, would go a very long way. The second is around standards and accompanying guidance. The same thing really goes with the case in New York, that having one template which is detailed and a set of standards that go along with it. The form in New York is very detailed, would allow for minimum variation in how data are used and submitted and the kinds of data that should and can be submitted. So it's very prescriptive, but it reduces the number of errors because it really requires some conformance to a rigorous and detailed standard. So those are other considerations around standards and accompanying guidance that appear to be working, or at least working towards a solution in other states, in New York in particular. The third is around healthcare resources and diversity. And we can look at Maryland and Washington and Colorado, for example, and look at some of the examples they've done. And when, Washington can have their Medicaid managed care groups look at a quarter of their directories every quarter, that's one thing. But looking at California, we've got 100,000 physicians in the state. We've got 280 delegated groups, 38 million Californians, and hundreds of hospitals. It is a much, much larger task, order of magnitude bigger than a state like Washington or even Colorado. And that does prove significant in terms of the level of effort that's required across the whole health system. And so there does need to be some thought as to how best to support this in California. There, as you can imagine, can be considerable costs that would be borne to create the infrastructure that's needed for this, and those costs have to be borne by someone. And whether that gets translated over to consumers who buy the product, those are issues that have to be confronted when you're looking at a state as large as California. And the last is around improving consumer decision-making protections. Now, directories can actually play an important role in educating consumer understanding of health coverage. And the diversity, again, of California is one such that it is going to be very important to support consumer decision-making. So, for example, there are large ethnic populations that have very specific cultural sensitivities to how they get care and what happens in an encounter. And so being able to buy a product and to be able to use that product and find a physician that understands linguistic and cultural issues is really important for a large segment of the population. And directories can help do that by not only helping to convey what languages are spoken of the practices, but by providing other information that can help inform consumers. So I think, Amy, at this time, why don't I turn it over to you so we have plenty of time for questions, and we can do that as soon as you're ready.
Great, thank you so much. So you can go to the next slide, Lauren. So just to remind folks, we've had a number of great questions come in already. Just to remind folks, if you do have questions, you can go ahead and submit them using the chat function to the host and the presenters, and we'll queue those up and try to fit all the great questions we've gotten in here. I also just want to remind people that this webinar will be posted within a week. We had a few questions about that as well. And we do have an issue brief, which will go into a little more detail than we've been able to do today. That issue brief is forthcoming. And then related to that, we had a specific question about being able to get links to the California templates and also to some of the materials that New York uses. And I think we'll be able to certainly post that on the website, perhaps in a revised version of this webinar, of the slides for this webinar, and it will certainly be in the issue brief as well. So let's see where to start with your great questions. We're going to start with we had a few sort of factual questions related to the Medicare Advantage organization requirements. So Jonah and Keith, 2 questions on that. First of all, is the requirement on the plans, is there a requirement to confirm that provider data that they get, or is there is the requirement on the plans just to do the outreach to the provider, right? In other words, is it an incoming? Is there a requirement around the incoming as well as the outbound outreach to the providers, or not? And similarly, another factual question related to the Medicare Advantage organization requirements is what exactly does real-time mean? Is that defined? What is the standard?
Well, so the guidance is for MAOs is to create a structured process to assess the availability of the providers and to update these online directories in real time. I don't know that they actually defined what real-time means, but what the guidance actually also described is that CMS is going to monitor compliance, and it will do so by engaging a contractor to verify accuracy. So it is going to actually go out with a third party to audit these directories, and it may take action against, CMS may take action against Medicare Advantage organizations that fail to comply. It could include civil monetary penalties and enrollment sanctions. So whether I don't know if they specified what real time means. I don't know, Pete, if you knew offhand, or if it's defined in the 2015 regs.
Yeah, I don't think they define real time, but I think the idea is that basically as they're coming in, which is to say that's a much stricter guideline than is generally. It's generally weekly or quarterly or biweekly. So even seeing the words real time is somewhat encouraging.
Great, thank you. Okay.
Amy.
Oh, go ahead. Yeah.
I'm sorry. I just wanted to also mention that in the appendix, there are links to all of the federal regs that we spoke to, along with a little bit more detail.
Great reminder, thanks. I don't know if people had time to look through those appendices, but there is a lot of good information in there. Great, so then another question related to industry standards around data, the data standards and the data integrity. So you all mentioned that there really is no federally mandated or industry accepted standard for that. Is there a local standard anywhere, or have you seen a foothold where, like a single carrier or a region has been able to essentially set a standard for their particular area?
Is this for California, Amy?
Specifically in terms of data standards and data integrity. And you could speak to California, but I think the question was more related to, the states in which you did the research.
Right. Well, in terms of the states who did the research, Keith, I think we only found that New York was the only state that really had a standard that really came from the state government, was ultimately sort of a mandated standard template used for a variety of purposes, but it ultimately drives the directories for both Medicaid and for their marketplace. I don't think we saw any other in Maryland or Colorado or Washington. I don't think we saw any other entity that was sort of pushing for and advancing a single standard. They tend to be using whatever they had internally built.
Yep, I would second that. I would say that we did see some of the larger carriers that operate across, either a number of states or in a number of different markets have developed internally some standard templates that serve as sort of a base or a floor that they know, for example, they need to ask for, X, Y, and Z data, and then depending on what state or what specific market they're looking for that data, they'll layer on top extra things onto that. So there has been some development, but it's all proprietary of sort of a floor that they're then able to modify from there. Right.
I mean, in California, I would be interested in others' opinion, but groups like ICE, like the Industry Collaborative Effort, they've been these sort of cross-health plan provider IPA groups that have been looking for and developing standards, these standards for how EDI, electronic data interchange, takes place and how information is transferred. I mean, there seem like there are groups like that in California that can be used in this state, at least, to help drive towards a standard.
And one of the other, I'm sorry, I mean, just real quick, one of the other developments that we're seeing in a lot of the new guidance coming out is the requirement to post provider directory data in a machine-readable format. So in a format that's publicly available that theoretically a computer programmer could write some sort of code for a program to take that data, digest it, and use it and display it in another way. And we've seen, I believe HHS and the Robert Wood Johnson Foundation just partnered to host a competition to see if there was a third-party sort of a tech crunch type thing to take machine-readable files with provider data and display it in either a more useful way or a more accurate way.
Great, thank you. One question specifically about a piece of data that is particularly challenging to ensure accuracy around, and that is the provider specialty. I know there's been actually a fair amount of discussion about that here in California. Is there, did you find anything in terms of ways that parties were able to resolve that? You know, it's very difficult to standardize provider specialty and match, make accurate matches on that particular data element. Did you find any? Were any of the states that you looked at or any carriers that you discussed, were they able to describe how that might be done?
Sure.
Go ahead, Pete.
Oh, I'm sorry. I was going to say, well, so there is some attempt to sort of clean, as we said. Again, there's no sort of source of truth for this, so a lot of it is done. We did hear some discussion of using things like National Provider Identifier and MPI, address, date of birth, or a state licensing number if something like that exists. But there's really no great way, and Amy, as you said, I think because things like specialty often, what's called one specialty somewhere may be called something else somewhere else. It really does create a lot of issues for figuring out which, are we talking about Dr. John Smith, Dr. J. Smith, Dr. John H. Smith? Are those all the same person, or are they all separate individual providers?
Yeah, Amy, we didn't see in the states we spoke with how they were addressing things like the detailed distinctions in subspecialties and subspecialty areas, and how they had created any kind of like a crosswalk to map each file with the subspecialty listing towards a master subspecialty or specialty list. I think that ultimately is certainly something that could be created, but when we talk to the carriers or the providers or even the regulators, they didn't go into the level of detail to describe how they sort of mapped out the plethora of different subspecialty designations to some master file.
Great, thank you. So to dip out into, up a little bit from that level of detail, How about patients and consumers? Did you find that patients or consumers played a role in any way in updating the provider directories? For example, notifying the errors to the carriers, and that that would lead to improvements in the provider directories. Was that discussed by any of the stakeholders?
It was. So consumers, in some cases, we heard that would contact the marketplaces and and they'd say, well, this provider doesn't practice here anymore. They've got a closed panel, or it's not, it's the wrong provider. They're not listed properly. And then the marketplaces, in each case, we heard the marketplace would turn around to the health plan and say, we received this input. Could you please, research? And so it would be the health plan that ultimately would make the change, or would do the research and make any changes as necessary. And then similarly, when we talk to carriers, they also would receive input from consumers on this front. It is kind of interesting because we asked directly, well, what's the role of consumers in updating these? And we heard that, I think it was Washington, I think it was Health Plan Finder, but I can't recall exactly, was expecting, they actually set up their call center to be able to address this issue, and they got something like half a dozen calls in the first week related to this particular issue, and they kind of they did not increase over time, they actually decreased. So they were, at least one of the marketplaces were expecting a lot more sort of consumer input and feedback on the directory issues, and they didn't see it. It didn't mean they didn't have them, it's just the consumers were not calling about that particular issue.
Great, and then similarly, did you hear perhaps from some of the consumer advocates you interviewed or from others any information? I know this wasn't the focus of the research, but did you hear anything about the consumers' preferred formats for information, for getting this information? Any insights into that?
You mean in terms of what? Whether it's displayed electronically or? Yeah, electronically,
linked to the marketplace versus, in some separate, freestanding site, et cetera.
Right.
Again, I know that wasn't the focus of the research, but just wondering if any comments came up about that.
No, but the only thing that came up relative to this that I think was telling was when we talked to an enrollment assister, and they noted that the state marketplace, when they were signing up patients or assisting patients, they would both direct the patients to the health plan site or to call the health plan, and not to use the directory of the state because they didn't feel it was accurate and a good way of determining whether a provider was there or not. Ultimately, they said the best thing to do is to call the plan, because they felt even the directory that was on the website may not be accurate or as accurate as what an individual who was at the plan could tell you about the network. It doesn't really get to the point of what consumers wanted in terms of electronic versus paper, but it does certainly speak to what some of the assisters were doing to try to help patients identify providers when they're buying insurance.
And I'll also add that that what do consumers want question didn't really ever seem to be asked, and I think it's a good point that this really is a consumer-facing tool. And so as we move forward creating provider directories, I think it really is worth considering what format and how usable a directory is. Like I said before, as I mentioned with the data elements, there's this balance between how much information is too much information and how much is not enough, and I think that also factors into how usable a directory is and looks. That's really something that should be taken into consideration as we move forward.
Right, right. I mean, a consumer their biggest priority may be does the individual speak Spanish? And that's what their search criteria is focused on versus, some other criteria. So those are issues that I think are really important to consider.
Great, thank you. So we have a lot of other questions. I think what I'm going to, but we're running out of time here. So I think what I'm going to do is we will take down these questions. We will try to ensure that we get answers to folks. Everything will be posted at chcf.org. One specific question I had was how to access the appendices. The appendices are at the end of the PowerPoint if you just scroll through to the end, and there's some hyperlinks there to some resources. Another specific question I was asked was if we have a more specific date for the issue brief release. I would say with the, it will be out within the next couple months, if not sooner than that. And certainly, if you're on the CHCF mailing list, you'll get a notice about that when it comes out. And the PowerPoint will be certainly downloadable once it is posted on the CHCF website. And again, I'm sorry if we didn't get to your questions. We will try to, consolidate all the questions and make sure they get answered. And there were a number, I just want to say, there were a number of suggestions about additional research, things that we didn't look at. For example, a great suggestion, and one that we've been talking about quite a bit here, is looking at non-healthcare sectors. How do they do these types of things, right? And some non-healthcare sectors have been able to, do similar kinds of, data consolidation with a much greater accuracy. In settings where things are rapidly changing, just as they are here, in the provider network context. So we certainly appreciate those suggestions. This research didn't do that. It focused narrowly on these 4 states and what we could learn from them, but happy to take suggestions about additional research we can undertake in the future. So thanks everybody for joining. Thank you, Jonah and Keith, and look out for the report that will be coming out in the near future. Take care, everybody. Bye-bye.
Thank you. Bye-bye.